It's going to benefit us in terms of our scope of practice, what we do, where we're going. I think in the future, we'll be able to order imaging. We're seeing that happen. I think in the future, we'll be able to be involved in perhaps injections and or some meds that are appropriate, like pediatrics, for example, and baclofen and the use of Botox and those kind of things.
Hi everybody, Dhinu Jayaseelan here, editor of the independent study courses for APTA Orthopedics. I just got off a conversation with Dr. John Heick, who's an expert in the area of orthopedics, neuro, sports, but also has a really interesting background in the primary care setting. And so we put together a course around the PT in the primary care setting, and we got a chance with Dr. Heick to talk about the history of PT in primary care, maybe where we're going in that sense, maybe what we can do as clinicians to feel a little bit more confident in that setting if we want to practice there. So hopefully you get something out of this discussion. And as always, if there's any discussions that we need to have, please feel free to reach out. If there's anyone you want me to talk to or have some conversations around, please feel free to reach out. And if there's any course content that we're missing or we need to add to our repertoire of what we can offer you, please do reach out and let us know, because we're here to serve you and the members. So please, hopefully you get something out of this discussion, and looking forward to having more of these. Thanks. All right, Dr. Heick, thanks so much for joining us today.
Happy to be here.
So obviously you've had a lot of roles within APTA Orthopedics. You've been involved in a number of different ways for a long time. But for those that don't know you personally or kind of what you're doing right now, do you mind just giving us a brief intro of what you've been doing kind of professionally and then what you're doing now?
Sure. Yeah. I just finished up my term, if you will, as editor for OPTP. I have wrote the ISC in the past and been involved in the ISC work group in terms of independent study courses on differential diagnosis, screening for differential diagnosis. I work in Northern Arizona University in Flagstaff. I'm full professor, super involved in orthopedics and in all the different areas for orthopedics, with interest in imaging, probably primarily for the SIG, and got interested in this primary care thing probably when I was in the Air Force and worked in a primary care clinic, and then I was a medic in the Air Force taking care of patients on the plane, which then led to me being a physical therapist. And when I became a physical therapist, then was able to work in the emergency department in practice as one of the things I did. And so it was super cool to sort of see all of those things sort of shape where this has led to primary care PT.
Mm-hmm. And so for the listeners and everyone kind of paying attention to this discussion, you've been a member of our advisory panel also for the ISC's independent study courses. And so we have a number of people that we kind of collaborate to create courses. And one of the topics that has consistently come up of something that might be of interest to our members is the PT in the primary care setting. Right. And so we were really excited to be able to put together a course around that. And we were happy to have you talk about that. But honestly, I think when we talk about the PT in the primary care setting, that seems somewhat nebulous still in terms of what that actually means. When we talk about, primary care physician is maybe the first person that you see that shuttles you off to somewhere else if you need to be. But in some ways, we start to think about maybe the PT that's got direct access privileges already does that. Can you kind of explain your thoughts on how you would define maybe the PT that's a primary care practitioner, and maybe how that's similar or maybe different than somebody who's got direct access?
Yeah, I think what winds up happening, especially with these terms, we get these terms are like buzzwords, like direct access when you think about that, or primary care PT. Aren't they the same thing? And people get them confused quite often. I think the cool thing about primary care PT, though, is that maybe direct access is a part of it, right? But direct access is not required to be part of primary care. So direct access is how the patient gets to us, right? And when we think about that primary care PT, the primary care therapist is in multiple settings. So I think part of it, we have to sort of think back to what is direct access and what does it allow us to do. And I think that answer then is clarified when you know a little bit more about direct access. There's really three different things for direct access, right? There's unrestricted, and that's what we all want, is to have unrestricted direct access. That means the patient comes to us, they don't need a referral, they knock on our door, they enter, we treat them, and we continue to treat them. There's provisional and there's limited. So unrestricted, provisional, and limited direct access. When we think about unrestricted, there's only 21 states in the United States that have unrestricted direct access. And this source is APTA, if you wanted to look that up. So that's a problem to me, that only 21 states we have what we want in terms of direct access. And that means then that the patient really has the ability to get PT without a referral. Provisional is probably across the states, probably the second largest group. That really means they limit how many visits that a patient can receive physical therapy, right? And or there's a referral requirement for different types of interventions. What it is that we do, they're going to say you can't do that for this population. So if we have provisional direct access, that's going to limit what we have available. And then there's limited. And so when we think about direct access, it was just last year, Alabama was the last state to receive direct access, which is a little bit upsetting that it's taken this long. Uh, the other states, I think, is Mississippi was also another state that was one of the last states to jump on in terms of direct access. So primary care PT really is unique because what it allows us to do is have a larger breadth and depth in terms of seeing patients. Its main focus, though, is to triage patients and or refer those patients. So uh, we know as physical therapists, we are doing that already, but what it allows us to do for primary care is a larger number of patients across multiple areas, right? So pediatrics, geriatrics, neuro, sports, ortho, all of these patients then could be coming to see us. And that's unique in terms of that a variety of patients, but then also the complex patients. So, for example, I worked in emergency department, and in the emergency department, we saw all of those types of patients. You know, we are really good at treating low back pain. We are really good at neck pain. We are really good at dizziness and vertigo and fall prevention, and all of those things are conditions that come to the emergency department very often. So if we think of like an orthopedic specialist, then obviously they're doing orthopedics. Whereas primary care, we're doing all of these things. So the easy answer for that, which is hard to write, is primary care physical therapist is all of the above.
Hmm. Yeah, and it sounds like that saying it's more of like a jack of all trades kind of scenario, where you kind of have a little bit more expertise in a lot of different areas to figure out when does somebody need to go somewhere else, but also being able to treat and evaluate maybe a bigger breadth and scope. Um, so so that's actually something that I think we've tried to do actually with direct access, and being able to identify when somebody maybe doesn't fit what our skill set is. Um, and direct access has been around for a long time too, or the thought of it has been. Um, can you give me like a little bit more of a background though of like when has primary care started? Because when we talk about like different privileges and being able to triage, you spoke to the ED. That's a very common one that we think about. I
Right.
think about the military as being
Yeah.
one that people have different privileges there, and maybe in rural settings, people have to have a bigger scope of your own practice. Um, where did this start, and where are we now, would you say, when it comes to the PT and the primary care setting?
Yeah, it really started in the military, like you mentioned, and when you think about all of the different conflicts that have happened, um, as I mentioned this in the monograph as well, and you'll see within the monograph for those that do purchase the monograph, and I highly recommend it, is I do interview a number of people and that have worked in the military system, but also within the civilian sector, and get their perspective. And so, really, it sort of happened in the Vietnam era, in which there was not enough physicians, and so they extended that to physician extenders, as they were known, in physical therapists were one of the groups that were allowed to do so. And so that has, of course, in the military, allowed individuals and that are physical therapists to, order imaging and order lab results, appropriate lab tests. And so that's where it started. If we can take that model, and back to your point about where is it going, and put that into the civilian world, I think that is where we're really going. In my view, I personally see every single outpatient clinic and hopefully provider within the clinic, but at least I could share them, having dynamometers and having diagnostic ultrasound units to be able to help in terms of assessing that individual, to be able to say, no, this is what it is, and here's the proof. And then being able to send that off as a file to the physician or insurance or what have you, to sort of say, this is what it is, and this is my plan of care. So I hope that technology allows us to get there, so that we can really zero in on what it is that we're doing in orthopedics and help.
Yeah. Yeah, and you spoke to a couple of things that I think are becoming more widespread and useful in clinic, and the value of handheld dynamometry and ultrasound, I think, is being demonstrated in it. And it's easier to justify having those pieces of equipment in your clinic. Um, Again, when I think of primary care, again, I'm thinking of a specific setting in my head, at least, is the military ED, somebody out in the community, more of a rural community. But I've always worked in an urban setting, and
Yeah,
it sounds like the skill set that the primary care PT needs is something that an urban setting PT needs too. Um, when do you when do you think that PTs have the skills to be primary care practitioners where other providers are available? Like when do I feel confident, and when would you feel confident with PTs being the primary care person? What skill set do you think differentiates us from somebody that maybe doesn't have that primary care expertise?
uh, I think it takes exposure, experience, and I think seeing a wide variety of different patient conditions. I didn't fail to mention, like, pelvic health, for example, is one of the aspects that is also within primary care. I'm not a pelvic health expert, but in terms of being able to refer and evaluate that patient, absolutely have that ability. But in terms of your question about when, can you help me with that in terms of?
Yeah, I guess I'm just trying to figure out, when I have a graduate student, they come out and they're entry level and they're able to evaluate and manage simple to complex individuals. Would you feel confident with our new grads as it pertains to entry level DPT students, um, to be primary care practitioners, or what do you think it takes for somebody to say, I'm confident that this person's an expert primary care person
Gotcha.
compared to
Yeah,
an ortho person compared to a neuro person?
yeah, I would. I think the experience aspect, and some people takes longer to sort of develop that experience to feel confident enough to do that. I don't think it's an entry level thing, and that's part of the reason why we're putting this forward for it to be a residency program. You don't. It's not required to do a residency to do primary care, but I think that you have to have that exposure across multiple areas to sort of know what's the most common conditions. I put that in the monograph in terms of those conditions, some ideas in terms of how we might help those individuals. But I think we're getting, and this is going to be new in terms of primary care. We have been practicing it for a while, but the majority of physical therapists don't practice primary care. And so therefore, I think we're going to develop that, and as technology gets better. For example, in the monograph, we talk about the keel. We talk about a number of different tools that potentially will help. But I think that we're going to advance that and continue to get better with that. The federal section has done a nice job in terms of setting this up for primary care to come forward as a residency program. And the VA Veterans Affairs groups are already practicing this. So I think using the resources that we already have for the military, from the VA, and from the federal section, I think that'll help a whole lot of sort of saying, all right, what are the main things we need to focus on? And I think that'll be one of the benefits of a residency, in terms of offering that. Make sure that we do know when that person is ready to go.
Yeah.
To patient primary care.
Yeah, and I mean, experience, exposure, all those things are definitely going to help me feel more confident in treating and evaluating individuals. And I think you spoke to an important aspect of the mentoring piece, is somebody that's been around for a while, that's seen it for a while, to be able to mentor and guide someone that hasn't been in it as much. And a residency process would be a very useful process in that sense.
Yeah.
What other, and I'm hopeful that maybe this course might actually be helpful in that sense, to get people more up to speed and confident with their own skill set to be able to treat a wider breadth of individuals. From your perspective, what would you kind of guide individuals towards when it comes to continuing education or additional resources to feel and be a little bit more expert in this area, assuming maybe that they don't purchase the course, or they do, or they don't have access to a mentor in this area? What else would you kind of suggest this individual kind of do to feel more confident treating this population?
Yeah, I think being curious is probably the biggest item. I know a, that's down to the individual, but being curious about how to treat a patient with a certain condition, seeking help is another useful way to sort of spark that idea and that motivation to help that patient. And of course, knowing evidence-based practice in terms of investigating that. But I do agree the monograph is a great start. The reality is, for primary care specific courses, there's not a whole lot out there in terms of resources. I think the monograph will help. I think that's going to really help in terms of when the residency program kicks in. That I think will fill the gap in terms of making sure people are ready to go in that development of the residency program. I think that part of that will be that more resources will be pooled across these areas as we start to learn more and more. Again, it's sort of an evolving area. I think we also need to go back to the VA and to our military physical therapists and incorporate them and make sure that we're using their resources in terms of their experience, what they found work. For example, for imaging, in the past, military physical therapists have gone through a course. It's sort of a prep course to get them ready to make sure that they are ready to order imaging. Is that something that we need? I'm not sure. I'll let others weigh in on that in terms of that idea. I know there are individuals that have an APTA course, for example, on primary care that has just come out in the last 6 months. I also have a course with Seth Peterson through MedBridge, not selling anything, but there are other things out there in terms of resources. I think it's developing. But if you look at it, one of the things that we did in the petition for making this a specialization certification is we did have to specifically give the ABPTS and ABTRI what we have available, and we had to scan nationally and internationally. And again, there's not a lot of resources that are very specific to primary care, but I think that is going to get better and better as we advance.
Yeah. And obviously, as time goes on, as we put in work for things to get better, things are going to improve. You spoke to the residency and the process of specialization certification. Can you kind of speak to that? Because I don't know if a lot of people are aware of what's going on within that primary care.
Yeah, it is interesting when the House of Delegates is coming forward with a motion RC-17 this summer in July, and the number of people that don't know this process is pretty large in terms of did you consider this? Did you consider that? So just to put perspective into that, I think this originated in 2018. So the process in terms of starting the whole shebang actually started with the ABTA, and so the ABTA suggested we do this, and they sent out a practice analysis. The practice analysis involves surveying physical therapists. Is there a need? Is there not a need? That process came back. We submitted that to ABPTS, phase one and phase two. And in that process for both phases, there were some deficits. So what wound up happening is the federal section took up the lead, and Ashley Castle, very specifically, has done a fantastic job of leading the federal section in this process of going through phase one and phase two again. So years and years in the making is my point of getting to this process where it's going to the House of Delegates to be considered for residency and specialization. It's very much an involved process. I go through that process in the monograph to number one, point out the people that were involved in this process and all of the work that they did to get us to this point. I also point out and interview a number of physical therapists that are pivotal for us getting to this point. Because we always, when you think about the expression of we stand on the shoulder of giants, we have some giants in orthopedic practice. We have some giants in physical therapy practice that have got us to this point. And so I felt like we needed to highlight those individuals because all the work that they've done has led to this point.
Yeah, it's a long process. It's a very rigorous and very tedious process, it sounds like, from what I've understood.
Yes. Tedious is good. Meticulous is another word. Yes.
Yeah, a lot of work goes into it. I'm glad someone else did that work. So, but there's a lot of work being done, and this is new. And so I'm really happy that we're creating this content around primary care so people feel a little bit more confident kind of moving into those positions that are so really needed to treat people and make the community well, right? Not just in different settings that we think about with military, ED, whatever. So with your background, having been in the military, then coming into a PT setting in the ED, now you got your background in sports, neuro, ortho, and then teaching, specifically around the primary care setting, right? What would you want our listeners to kind of think about or kind of take away as some key points that you want them to know about this topic that they wouldn't find somewhere else potentially?
When we think about primary care as a whole and where we are in the profession, and number one, of course, like we've mentioned, the process to get there. But I think the other part is then thinking not just with one lens, but looking at where we're going. So, when we think about what we're going to be able to do in the future in terms of musculoskeletal practice, but when you think about the number of physician shortages that we have, they say 121,000 short by 2030. That's like in 5 years. And so if we don't have all those physicians that are working in a primary care setting, we have other professions that are trying to move and fill this gap for primary care. We are perfectly positioned to meet this, and we should rise up to meet this because it's going to benefit our patients. It's going to benefit us in terms of our scope of practice, what we do, where we're going. I think in the future we'll be able to order imaging. We're seeing that happen. I think in the future we'll be able to be involved in perhaps injections and or some meds that are appropriate like pediatrics, for example, and baclofen and the use of Botox and those kind of things. I think that's happening. I think that's going to continue to happen. And I think we're going to get better in terms of being known as musculoskeletal experts. We already are. We know that, but the rest of the world doesn't know that. And so I think that's that's where we're going. And I think primary care PT is one step towards that. Doesn't mean that we have to go there, but I personally think that that will lead us to that and being able to treat our patients appropriately and be recognized as a musculoskeletal expert. When I have a tie that has spines on it, and when I go out in the public and I interact, whether I'm at Starbucks or wherever, they say, "Oh, are you a chiropractor?" And I want to slap them, not because I hate chiropractors, but it's like, no, I'm a physical therapist, and they don't associate that, and they should. And if we can convey that to the public, I think it'll advance our profession.
Yeah. Yeah, I go out in the public with this shirt on, and they think I'm gonna give them some exercises, some random exercises, and they don't know the scope. I think it comes back to messaging. I know we know how much we know. We know how much we don't know. We still obviously have a lot to learn and
Absolutely.
room to grow, but we are well positioned to help people that are not being helped elsewhere. And I think being in the primary care setting is a wonderful opportunity for us. I think as we start to define what that looks like, we're going to be able to lend ourselves into helping students be better at that when they get out of school. But I think it does really require, at this point, it sounds like those that have that expertise to help others get that expertise too. And so these mentorships, these residencies, that's really going to be an important process to help us feel more confident as a profession. And so I really do appreciate all the time and the effort that you and your colleagues have put together to put this forward, and obviously within this course. But I do want to just take a second to say thank you for having this conversation with me. Hopefully it's helpful for other people to kind of know what primary care is, what it's not maybe, but then also start to work on getting some more information, expertise in that content area so we can help people. So
thank you, Dhinu. I appreciate that. I appreciate the chance to talk about it, and hopefully the House of Delegates will have a chance to stand up and go hoorah in terms of where we've gotten to this point.
yeah, time moves quickly and also slowly, so we'll figure out how long it takes, but it'll get there. And I appreciate your work on it for sure. And thanks so much for talking to me about it.
You're very welcome.